Hello, welcome to webinar today. I'm so happy. I'm just checking everything is fine. Right. Today we are going to see the management of hypertension and how to make it easy to rock your consultations and pass your exams with confidence and ease, right? Okay, let's rock. Before we start, please tell us where you're from. Have you come across any difficult cases so far? Please share your questions, struggling points in the chat. If you're watching this video in the YouTube, then share it in the comments box. I would love to see what you want. Thank you. Right. My promise today is to have fun. Yes, I mean it. It's Sunday morning here in UK. It's beautiful weather. And let's have fun. Let's see how to manage hypertension easily in your exams. And your promise is turn off distractions like your mobile, Facebook, emails, everything, and have a pen and notes and water or coffee or tea and get ready. Let's rock. Okay, here is another poll question. Please answer which topics do you want to see in our next webinar. For example, pediatrics or men's health, sexual health, dermatology. Please share it. Dermatology, please share it. Dermatology. I can see my same echo. Right. Let's see the next. You're in the right place if you're confused about the different consultation and communication models. You don't know how to prepare effectively for exams like MRC GPCSA in UK, GP exams in Australia, Canada. And you feel overwhelmed and don't have the time to try and figure it all yourself. You're not really sure what's working now in the exams and you need help identifying easy steps to pass it. You want to learn from someone who has personally achieved it and can guide you step by step. You have a strong will and determination to pass your exam this time. This last point is very vital because you're the key factor for your success. You have to take 100% responsibility in taking massive action, right? And you will be working. Why is this not working? Why can't I, get the relevant tips and tricks to pass my exam, to rock my consultation? The 3 words I can say is I can relate. Yes, I'm just like you. I'm a mummy to Adi, GP in Yorkshire, UK. And I have got gold medals in India when I was going through school and college. And in UK, I have done so many diplomas and post-graduation. I have studied in India, UK, and US. But the truth is, I struggled just like you during my consultation skills examinations. I went through multiple books, courses, diplomas, and I learned by trial and error what to do and what not to do, and ended up identifying what actually works during our medical consultations. So then I thought knowledge is power. So we need to bring knowledge to our people, to other students globally. And I started this free online website, csasmartgroup.com. You might have known through this website. You're already a member. You might have received my free videos and free ebook. And I started it mainly for the doctors who felt like the lost little Nemo, because I felt like one. And it has helped thousands of students all over the world. I'm so happy about this and proud of this. Then I realized a couple of years ago, knowledge is not power. Execution trumps knowledge every day of the week. As my mentor, Tony Robbins, said, that's absolutely true. It doesn't matter how much knowledge we have, but it's up to the point how much we are executing it. So I started a Consultation Skills Academy, through which we are offering CSS Smart Success online course, for which you will have this invitation later on in this webinar. And if this resonates with you, please join us and we will be happy to have you on board. And it has supported hundreds of students globally. Okay, before starting this webinar on hypertension, the disclaimer, it only covers a general overview of the management of essential hypertension in adults, some case scenarios of varying levels of complexity reflecting day-to-day practice. By no means it is a comprehensive review of hypertension. I would recommend the full guidance documents from NICE, European Society of Cardiology, hypertension bodies, to those who need more in-depth information. These are the particular groups which we will not be covering today, like people with diabetes, young people, pregnant women, secondary causes for hypertension, and acute hypertension problems. We are going to see why hypertension is important, not only for exams, but also in our real life. And we will briefly see into the NICE guidelines, and then the clinical management of primary hypertension in adults, and few example case scenarios. I'm planning to do another webinar on just the example cases, because it's too much to cover today. Right. Why is it important? Hypertension is one of the most preventable causes of premature morbidity and mortality in UK. Hypertension is very common globally. It is the most frequently managed chronic problem in general practice. It is accounting for £1 billion in drug costs alone in 2006. Hypertension is serious. It is a major risk factor for stroke and coronary heart disease. It's a major contributor to chronic heart failure, chronic kidney disease, and its progression. And the prevalence is influenced by age and lifestyle factors. More than 25% of the adult population are suffering with hypertension. Among them, 50% are more than 60 years old. With the aging population, the prevalence of hypertension and requirement for treatment will continue to increase. So it's vital for us doctors to know about how to manage it effectively. Let's see the risk of mortality. Each 2 mm mercury rise in systolic blood pressure alone associated with increased risk of mortality. You can see 7% increased risk from ischemic heart disease and 10% increased risk from stroke. And in this slide, you can see how the cardiovascular mortality risk doubles with each 20/10 mm of mercury blood pressure increment. Imagine 135/85 causes double the risk, and 155/95, it quadruples the risk. And there is 8-time increase in the risk when the blood pressure is around 175/105. So the benefits of lowering blood pressure, why we have to effectively lower the blood pressure? Because it produces average reduction in stroke incidence to around 35 to 40%. And it will reduce around 20 to 25% decrease in MI, myocardial infarction, and 50% reduction in heart failure. Imagine how much we can make the patient's life better. It is very important in our exams scenarios as well. We have to be 100% patient-centered, and we should offer treatment and care after taking into account people's needs and preferences. People with hypertension should have the opportunity to make informed decisions about the care and treatment. And good communication between us and the patients is very essential. It should be supported by evidence-based written information tailored according to the patient needs. And it should be culturally appropriate as well. It should also be accessible to patients with additional needs, as learning disabilities who do not speak or read English. If the patient agrees, families and carers should have opportunity to be involved in decisions about treatment and care. Families and carers should also be given the information and support they need. Let's see the NICE guidelines reference definition. This is Clinical Guidance 127, published in August 2011. According to it, they have defined hypertension into three types. Stage 1 hypertension, where the blood pressure is 140/90 or more. And the subsequent ambulatory blood pressure monitoring or home blood pressure monitoring average around 135/85 or more. So this is very important in the definition. We have to make sure to get both clinic blood pressure as well as ABPM or HBPM. In stage 2 hypertension, the blood pressure is 160/100 or higher than that, and ABPM or HBPM average is 150/95 or higher. These are the magic numbers, so you got to memorize that. There is no other way. And when the systolic blood pressure is 180 or higher, or either one of the right, or the diastolic blood pressure clinic is 110 or higher, we call it as severe hypertension. This is the magic number 2, 180/110. Please remember and mark it. You can have cases on this. This is the classification according to European Society of Hypertension, European Society of Cardiology. So you can see there are like high, normal, high, grade 1, grade 2, grade 3, and isolated systolic hypertension. And more or less the Australian Heart Foundation, and they follow similar classification. You can get the relevant PDF in heartfoundation.org.au. And there are some definitions available depending upon office and out of office blood pressure levels. Okay, what is the difference between systolic and diastolic? Systolic blood pressure, it continues to rise throughout life. It's a major risk factor for cardiovascular disease and more important than diastolic blood pressure, especially if the patients are above 50 years of age. Diastolic blood pressure, it rises until approximately 50 years and tends to level off over the next decade and may remain the same or fall later. Diastolic hypertension predominates in people less than 50 years of age, and it's more potent cardiovascular risk factor than systolic blood pressure until age 50. Okay, let's see about the measuring blood pressure. Nowadays, we are using automated devices more commonly. But please check the pulse before doing that. If there is any pulse irregularity, for example, atrial fibrillation, measure blood pressure manually using direct auscultation over the brachial artery. When measuring blood pressure in the clinic or in the home, standardize the environment and provide a relaxed temperate setting with the person quiet and seated and their arms outstretched and supported and legs uncrossed. If using an automated blood pressure monitoring device, ensure that the device is validated and an appropriate cuff size for the patient's arm is used. When considering a diagnosis of hypertension, measure blood pressure in both arms. If the difference in readings is more than 20 millimeter of mercury, repeat the measurements. If the difference in readings between arms remains more than 20 millimeter of mercury on the second measurement, measure subsequent blood pressure in the arm with a higher reading. Make a note in patient's records and remind the patients as well. If blood pressure measured in the clinic is 140/90 or higher, then take a second measurement during the consultation. If the second measurement is subsequently different from the first, take a third measurement. Record the lower of the two measurements as the clinic blood pressure. Blood pressure tends to settle during the consultation, so make the patient to feel at ease. If the clinic blood pressure is 140/90 or higher, then offer ambulatory blood pressure monitoring to confirm the diagnosis of hypertension. If a person is unable to tolerate ABPM, example like drivers, home blood pressure monitoring is a suitable alternative to confirm the diagnosis of hypertension. If the person has severe hypertension, consider starting antihypertensive drug treatment immediately without waiting for the results of ABPM or HBPM. It is very vital in exam case scenarios. During your assessment, a thorough evaluation of all patients includes taking a full medical history, including relevant drug history, family history, psychosocial history, drug misuse, the dietary and exercise pattern, smoking and alcohol history. These are all very vital and which helps you to offer the best management care according to the patient's need, and perform a physical examination with particular attention to cardiovascular system. While waiting for confirmation of a diagnosis of hypertension, carry out investigations for target organ damage such as left ventricular hypertrophy, chronic kidney disease, and hypertensive retinopathy, and a formal assessment of cardiovascular risk using a cardiovascular risk assessment tool like QRISK. If hypertension is not diagnosed, but there is evidence of target organ damage, such as albuminuria or proteinuria, consider carrying out investigations for alternative causes of the target organ damage. If hypertension is not diagnosed, measure the patient's clinic blood pressure at least every 5 years subsequently, and consider measuring it more frequently if their blood pressure is close to 140/90. When using ABPM to confirm a diagnosis of hypertension, ensure that at least 2 measurements per hour are taken during the person's usual waking hours, and use the average value of at least 14 measurements taken during the time to confirm a diagnosis of hypertension. Increased BP readings on ABPM are more strongly correlated to end organ damage than one-off measurements. When using home blood pressure monitoring to confirm a diagnosis of hypertension, ensure that for each blood pressure recording, 2 consecutive measurements are taken at least 1 minute apart and with the person seated. Blood pressure is recorded twice daily, ideally in the morning and evening. Blood pressure recording continues for at least 4 days, ideally for 7 days. And discard the measurements taken on the first day and use the average value of all the remaining measurements to confirm a diagnosis of hypertension. Refer the patient to specialist care the same day if they have accelerated hypertension, that is blood pressure usually higher than 180 over 110, with signs of papilledema and or retinal hemorrhage, or suspected pheochromocytoma with symptoms of labile or postural hypertension, headache, palpitations, pallor, and diaphoresis. You have to refer the patient on the same day itself. These are the very important case scenarios in day-to-day life and in the examination as well. So please practice on those cases. Consider the need for specialist investigations in people with signs and symptoms suggesting a secondary cause of hypertension. And use a formal estimation of cardiovascular risk to discuss prognosis and healthcare options with people with hypertension, both for raised blood pressure and other modifiable risk factors. Estimate cardiovascular risk in line with the recommendations on identification and assessment of CVD risk and lipid modification. For all people with hypertension, offer to test for the presence of protein in the urine by sending a urine sample to check albumin-creatinine ratio, ACR, and the test for hematuria using the reagent strip. Take a blood sample to measure plasma glucose, electrolytes, urea, creatinine, sodium, potassium, and estimated glomerular filtration rate, EGFR, and serum total cholesterol and HDL cholesterol. Examine the fundi for the presence of hypertensive retinopathy. Arrange for a 12-lead ECG so that you can look for any left ventricular hypertrophy, atrial fibrillation. Lifestyle interventions is very vital. Lifestyle advice should be offered initially and then periodically to people undergoing assessment or treatment for hypertension. Ascertain people's diet and exercise patterns because a healthy diet and regular exercise can reduce blood pressure. Offer appropriate guidance and written or audiovisual materials to promote lifestyle changes. Ascertain people's alcohol consumption and encourage a reduced intake if they drink excessively because this can reduce blood pressure and has broader health benefits. Discourage excessive consumption of coffee and other caffeine-rich products. Offer advice and help to smokers to stop smoking. Ensure people to keep the dietary sodium intake low, either by reducing or substituting sodium salt, as this can reduce blood pressure. Do not offer calcium, magnesium, or potassium supplements as a method for reducing blood pressure. Many patients might ask about the relaxation therapies. Yes, they can reduce blood pressure and people may wish to pursue these as part of the treatment. However, routine provision by primary care teams is not currently recommended. Inform people about local initiatives by, for example, healthcare teams or patient organizations that provide support and promote healthy lifestyle change. Now, let's look into the initiating and monitoring antihypertensive drug treatment. Offer antihypertensive drug treatment to people aged under 80 years with stage 1 hypertension who have one or more of the following, like target organ damage, established cardiovascular disease, renal disease, diabetes, or 10-year cardiovascular risk equivalent to 20% or greater. This is a magic number as well, you have to remember. And offer antihypertensive drug treatment to people of any age with stage 2 hypertension. For people aged under 40 years with stage 1 hypertension and no evidence of target organ damage, cardiovascular disease, renal disease, or diabetes, please consider seeking specialist evaluation of secondary causes of hypertension and a more detailed assessment of potential target organ damage. This is because the 10-year cardiovascular risk assessments can underestimate the lifetime risk of cardiovascular events in these people. Use clinic blood pressure measurements to monitor the response to antihypertensive treatment with lifestyle modifications or drugs. Aim for a target clinic blood pressure below 140/90 in people aged under 80 years with treated hypertension, and aim for a target clinic blood pressure below 150/90 in people aged 80 or over. Let's see the white coat effect. A discrepancy of more than 20/10 millimeter of mercury between clinic and average daytime ABPM or average HBPM blood pressure measurements at the time of diagnosis. So for people identified as having a white coat effect, consider ABPM or HBPM as an adjunct to clinic blood pressure measurements to monitor the response to antihypertensive treatment with lifestyle modification or drugs. When using ABPM or HBPM to monitor response to treatment, aim for a target average blood pressure during the person's usual waking hours of below 135/85 for aged under 80 years and below 145/85 for people aged 80 or over. Wherever possible, recommend treatment with drugs taken only once a day. Prescribe non-proprietary drugs where these are appropriate and minimize cost. Offer people with isolated systolic hypertension, systolic blood pressure of 160 or more, the same treatment as people with both raised systolic and diastolic blood pressure. Offer people aged 80 years and over the same drug treatment as people aged 55 to 80, taking into account any comorbidities. In most of the time, we need multiple antihypertensive agents to achieve target blood pressure. There are so many trials done, and the ALHA trial mentions about at least 2 antihypertensive agents are needed to get the target BP. There are many possible combinations between some classes of antihypertensive drugs. The preferred combinations in the general hypertensive population are represented as thick lines, so you can have a look. There are so many contributing factors for the patients who are hard to treat. Have to look into the obesity management, diabetes, black race, renal insufficiency, and the most important thing, non-compliance. So we can have cases on why with poor BP control. So we have to look into more in detail from the patient's history. We have to look into the poor treatment compliance, insufficient use of lifestyle modifications, significant alcohol consumption, use of substances with pro-hypertensive effect like cocaine, licorice, NSAIDs, steroids. Sometimes patient may have sleep apnea syndrome, undetected cause of secondary hypertension, irreversible target organ damage, volume overload with insufficient diuretic therapy or worsening renal failure or high dietary sodium intake and or hyperaldosteronism. Clinical conditions associated with resistant hypertension, it can happen around in 5 to 15% of the patients. It's a clinical state in which a therapeutic plan that has included attention to lifestyle measures and prescription of at least 3 drugs in adequate doses, including a diuretic, but it has failed to lower systolic and diastolic blood pressure at goal. So we must exclude inadequate therapeutic approach, scarce use of combination treatment, secondary hypertension, white coat hypertension, ineffective drug regimen, treatment compliance, and combined conditions. So, how to achieve target BP? Start with lowest dose of first drug. If the drug is not tolerated, change to a different class. If target BP not reached, add second low dose drug from the different class. If target BP still not achieved and both drugs well tolerated, increase the doses. Trial each dose regimen for at least 6 weeks. If necessary, use drugs from different classes in combination to achieve the target BP. About 50 to 75% of patients will not achieve blood pressure targets with monotherapy. This is the quick slide on our BHS summary of antihypertensive drug treatment. We will look into in detail now. There are 4 steps of treatment available. So important points to remember. Management is determined by assessment of absolute risk and evidence of end organ damage. Treat to target blood pressure, and lifestyle modification is indicated for all patients. In the step 1 treatment, offer people aged under 55 years, you can offer ACE inhibitor or low-cost ARBs. If an ACE inhibitor is prescribed and is not tolerated, for example, because of cough, dry cough, offer a low-cost ARB. Please remember, do not combine an ACE inhibitor with an ARB to treat hypertension. If the patient's aged over 55 years and to Black people of Afro-Caribbean origin at any age, offer step 1 antihypertensive treatment with calcium channel blocker. Very important, please remember this. Offer a thiazide-like diuretic if calcium channel blocker is not suitable, for example, because of pedal edema or intolerance, or there is evidence of heart failure or a high risk of heart failure. Remember this scenario because these are all very important in our daily day-to-day practice and in exams as well. If diuretic treatment is to be initiated or changed, offer a thiazide-like diuretic such as clothalidone. You can start like 12.5 to 25 milligram once daily, or indapamide 1.5 milligram modified release once daily, or 2.5 milligram once daily. In preference to a conventional thiazide diuretic such as benraflumethiside or hydrochlorothiazide. For people who are already having treatment with benraflumethiside or hydrochlorothiazide and whose blood pressure is stable and well controlled, please remember you can continue treatment with the same medicine. This is the hierarchy of BP lowering effect of ARBs, with the highest from asilsartan, olmesartan, and lowest to losartan. This slide will be useful for you to choose your ARBs according to the patient's blood pressure. The most effective combination is ACE inhibitor with or ARB with calcium channel blocker. It has particular role in the presence of diabetes or lipid abnormalities. Other effective combinations include ACE inhibitor or ARB with thiazide diuretic in the presence of heart failure or post-stroke, ACE inhibitor or ARBs with beta blocker. It is recommended post-myocardial infarction or in people with heart failure. But this is all started by the cardiologist. The another effective combination might include beta blocker plus dihydropyridine calcium channel blocker. its particular role in the presence of coronary heart disease. Please remember this slide. Avoid the following combinations. Thiazide diuretic with beta blocker, it's not recommended in people with glucose intolerance, metabolic syndrome, or established diabetes. And AZ inhibitor or ARB with potassium sparing diuretic due to risk of hyperkalemia. It increases the potassium. And also avoid the following combination. Verapamil with beta blocker due to risk of heart block, and AC inhibitor and ARBs, because in a large trial, combination therapy did not reduce cardiovascular death or morbidity in patients with vascular disease or diabetes, but increased the risk of hypertensive symptoms, syncope, and renal dysfunction. So, in step 1 treatment, beta blockers are not a preferred initial therapy for hypertension. However, beta blockers may be considered in younger people, particularly those with an intolerance or contraindication to ACE inhibitors and ARBs, or women of childbearing potential, or people with evidence of increased sympathetic drive. If therapy is initiated with a beta blocker and a second drug is required, add a calcium channel blocker rather than a thiazide-like diuretic to reduce the person's risk of developing diabetes. In step 2 treatment, if blood pressure is not controlled by step 1, offer step 2 treatment with calcium channel blocker in combination with either ACE inhibitor or ARB. If a calcium channel blocker is not suitable for step 2 treatment, for example, because of edema or intolerance, or if there is evidence of heart failure or high risk of heart failure, offer a thiazide-like diuretic. For Black people of African and Caribbean family origin, consider an ARB in preference to an ACE inhibitor in combination with a calcium channel blocker. If blood pressure remains elevated despite maximal doses of at least 2 appropriate agents, please reassess for non-adherence, undiagnosed secondary hypertension, hypertensive effects of other drugs, treatment resistance due to sleep apnea, undisclosed use of alcohol or recreational drugs, unrecognized high salt intake, white coat hypertension, technical factors affecting measurement, volume overload, especially with chronic kidney disease. Now let's see the step 3 treatment. Before considering step 3 treatment, review medication to ensure step 2 treatment is at optimal or best tolerated doses. If treatment with 3 drugs is required, the combination of ACE inhibitor or ARB, calcium channel blocker, and thiazide-like diuretic should be used. Resistant hypertension is the clinic blood pressure that remains higher than 140/90 after treatment with the optimal or best tolerated doses of ACE inhibitor or ARB plus a calcium channel blocker plus a diuretic, and please consider adding a 4th antihypertensive drug and seek expert advice. For treatment of resistant hypertension at step 4, consider further diuretic therapy with low-dose spironolactone, 25 mg once daily, if the blood potassium level is 4.5 millimoles per liter or lower. Use particular caution in people with a reduced eGFR because they have an increased risk of hyperkalemia. Consider higher dose of thiazide-like diuretic treatment if the blood potassium level is higher than 4.5 millimoles per liter. At the time of publication of NICE guidelines, Spinolac did not have UK marketing authorization for this indication. Please check it, and informed consent should be obtained and documented. When using further diuretic therapy for resistant hypertension at step 4, monitor blood sodium and potassium and renal function within 1 month and repeat as required thereafter. If further diuretic therapy for resistant hypertension is not tolerated or is contraindicated or ineffective, consider an alpha or beta blocker. If blood pressure remains uncontrolled with the optimal or maximum tolerated doses of 4 drugs, seek expert advice if it has not yet been done. Let's see patient education and adherence to treatment. Provide appropriate guidance and materials about the benefits of drugs and the unwanted side effects, sometimes experienced, in order to help people make informed choices. People vary in their attitudes to the hypertension and their experience of treatment. It may be helpful to provide details of patients' organizations that provide useful forums to share views and information. Provide an annual review of care to monitor blood pressure. Provide people with support and discuss their lifestyle, symptoms, and medications. Because evidence supporting interventions to increase adherence is inconclusive, only use interventions to overcome practical problems associated with non-adherence if a specific need is identified. Target the intervention to the need. Interventions might include suggesting that patients record their medicine taking, encouraging patients to monitor the condition, simplifying the dosing regimen, using alternative packaging for the medicine, and using a multi-compartment medicine system. It is very useful in elderly patients. Let's see the clinical management of primary hypertension in adults with example cases. Before we see the example cases, let me have some water. Okay. Mr. A comes in to see you for a routine checkup. His blood pressure today is 142/96. He's not known to be hypertensive. So what do? Bring him back next week for a repeat blood pressure, or ignore it and you have enough to do already. Or the third option is take a second measurement during the consultation. Yeah, put it in the chat box. What will you do? The answer is take a second measurement during the consultation. If this is substantially different, then take a third measurement and record the lower of the last 2 readings as the clinical blood pressure. Now, the repeat measurement is again 141/94. So how do you confirm a diagnosis of hypertension in this case? 3 options: nothing, this needs treatment ASAP, or return to clinic for 2 more blood pressure checks, or offer ambulatory blood pressure monitoring. What will you do? Right, you're right. Offer ambulatory blood pressure monitoring. If patient unable to tolerate this, home blood pressure monitoring is a suitable alternative. If the patient has severe hypertension, consider starting antihypertensive drug treatment immediately without waiting for results of above. Now, Mr. A agrees to ABPM. So while waiting for confirmation of the diagnosis, what should you do? Start drug treatment for hypertension. Nothing until the diagnosis is confirmed. Carry out investigations for target organ damage. Tell me, what will you do in the chat box? Yes, you're right. Carry out investigations for target organ damage, like left ventricular hypertrophy, chronic kidney disease, hypertensive retinopathy. Also, take formal assessment of cardiovascular risk using assessment tool like QRisk. These are the investigations to check for target organ damage. Urine analysis to test for proteinuria and send urine sample for albumin creatinine ratio, ACR, and test for hematuria. and organize blood tests to check plasma glucose, Usanease, estimated GFR, and serum total cholesterol and HDL cholesterol, and do the fundoscopy and organize for 12-lead ECG. Okay, if hypertension is not diagnosed, how often do you measure the patient's blood pressure? We have to measure the person's clinic blood pressure at least every 5 years subsequently. Consider measuring it more frequently if blood pressure close to 140/90. Now, Mr. A has stage 1 hypertension. He is 65 years old. Can you name any of the criteria he must have to be commenced on drug treatment? For patients less than 80 years with stage 1 hypertension, offer antihypertensive drug treatment if they have one or more of the following: target organ damage, established cardiovascular system disease, renal disease, diabetes, or 10-year cardiovascular risk equivalent to 20% or greater. If none of above, start with lifestyle modification. If under 40 and none of the above, consider seeking specialist evaluation of secondary causes of hypertension and a more detailed assessment of potential target organ damage. This is because 10-year cardiovascular risk assessments can underestimate the lifetime risk of cardiovascular events in these age group. Offer antihypertensive drug therapy to people of any age with stage 2 hypertension. So now let's look into the management. Offer people more than 80 years of age the same antihypertensive drug treatment as people aged 55 to 80, taking into account of any comorbidities. Use clinic blood pressure measurements to monitor response to treatment. If white coat effect suspected, consider ABPM or HBPM as an adjunct to clinic blood pressure measurements. Lifestyle interventions are vital and offer initially and then periodically. Find out about diet and exercise patterns and give advice as needed. Ask about alcohol consumption and advise to cut down if needed. Discourage excessive consumption of coffee and other caffeine-rich products. Ask about smoking and offer advice about stopping. Advise low dietary sodium intake. So this is the slide which gives you an overall view of what to do. This is old guidelines which has diuretic in step 1, but now we have moved on to the new guidelines where we use the calcium channel blocker or the ACE inhibitors or ARB depending on the age. There are the main changes in the new guidelines. We do not combine an ACE inhibitors with ARB. If calcium channel blockers are not tolerated or evidence of heart failure, can use thiazide like diuretics, same for stage 2. If diuretics commenced, use chlorthalidone or indapamide, and instead of conventional thiazide like benroflumethiside. However, if already on and BP is well controlled, no need to change to newer drugs. And in step 2, for Black people or African or Caribbean origin, consider ARB instead of an ACI in combination with the calcium channel blocker. In step 3, before considering step 3 treatment, review medication to ensure step 2 treatment optimal. And in step 4, for the diuretic therapy, you can use low-dose spironolactone, 12.5 to 25 milligram, if blood potassium less than 4.5 millimoles per liter. If it is above, then you can consider higher dose thiazide like diuretics. And always monitor blood sodium, potassium, and renal function within 1 month and repeat as required thereafter. If not tolerated, contraindicated, or ineffective, consider an alpha or beta blocker. Choosing drugs no change. Choose drugs which are used once daily, non-proprietary, and offer people with isolated systolic hypertension the same treatment as people with both raised systolic and diastolic blood pressure. And let's see the target blood pressure. If the patient is less than 80 years of age with treated hypertension, aim for clinic blood pressure less than 140/90. If used ABPM or HBPM, aim for BP less than 135/85. If the patient is 80 years or older, aim for clinic blood pressure 150/90. And if used ABPM or HBPM, aim for blood pressure less than 145/85. So these numbers are magic numbers. You got to remember, write it in a paper and stick to the wall, and keep always refer to this when you're dealing cases like this. Annual review of care to monitor blood pressure, provide people with support and discuss their lifestyle, symptoms, and medication. And next case is Mrs. B. She is 53 years old, Afro-Caribbean, and not known to be hypertensive. So blood pressure confirmed at 162/104. How would you classify this, and what class of drug would you commence first? So her blood pressure comes under stage 2 hypertension, and calcium channel blocker would be the drug of choice in this scenario because of her Afro-Caribbean origin. On reviewing her history, you note that Mrs. B has heart failure. Would this change your management? What drug could you use? Yes, this could change your management. You could use a thiazide-like diuretic instead of calcium channel blocker, and you could either use clothalidone or indapamide. The next case is Mr. C. He is 49 years old, white British, not known to be hypertensive, and his blood pressure confirmed at 181/94. So how would you classify this? What class of drug would you commence first, and how would your management differ? So he comes under severe hypertension, and you can commence with either ACE inhibitor or ARB. And we have to go straight to the treatment. Do not wait to confirm with ABPM or HBPM. This is very vital for your exam case scenarios. You should be able to prescribe with the proper dose and name of the drug. So practice this case. So blood pressure remains poorly controlled in Mr. C, and you end up on step 4. How would you like to try next? Provided the blood tests are normal, this seems to work. What is the target blood pressure for this patient, and how often do you review his blood pressure? So you can try low dose spironolactone 12.5 to 25 milligram. If it seems to work, then the target blood pressure, clinic blood pressure, should be less than 140/90. And you have to review him annually. This is very important case for your exams. When to refer the patient? The same day, urgent referral. If the patient has accelerated hypertension, blood pressure more than 180/110 with signs of papilledema or retinal hemorrhage, suspect a pheochromocytoma with symptoms and signs of labile or postural hypertension, headache, palpitations, pallor, and diaphoresis. Very important case scenario. And you can also refer if no response after 4 drugs have been used, seek specialist advice if you have not already. And consider referral if unusual symptoms and signs and symptoms suggesting a secondary cause, and there are symptoms of postural hypertension. And this is a quick slide for you just to go through all the step 1, step 2, step 3, step 4 hypertension treatment. Right. Believe me, you can do it. Dream big and take massive action. And I will teach you how. Don't worry about the how, because I'm here to teach you, and you have totally got this. And we can do it. If you like this teaching and training, please, I offer you the invitation to join us in our CSS Smart Success online program. You can get instant access. And if you join during this webinar, you will get a free Skype session with me, which is worth around £497. And you can see the orange button on your right hand. Yes, it's still there. If you click this button to join now, the orange button, it will take you to the new page and you can join us. And I'm happy to see you. And click this orange button to join now.